But IlluminOss is a custom conforming intermedullary implant. It uses a dacron balloon with a proprietary monomer that's light activated. So it works very much like an intermedullary nail, opening the canal and then inserting the balloon and then inflating. Next slide. Here's an example of showing what that balloon looks like when it inflates with the monitor, which is where we get our strength, stability, and our rotational control. The neat feature on this is it's not like a PMMA where you're working against the clock. This monomer does not cure until it's activated by the light source. Once it's activated and cured, it gives you the ability to augment, to again offer strength and stability. Next slide. We are indicated for standalone, for metastatic, and for supplemental hardware, which augmentation, which I believe we'll touch on tonight. But our solution having over 18 indications. Tonight we'll specifically talk in the femur, but again, metastatic, standalone, and supplement. It is critical to know that our approval for femur and tibia does require supplementing of hardware, either through plates or nails. Next slide. Dr. Halverson, I'd like to turn it over to you. Thank you.
All right, thank you everybody very much. So I was very excited to sort of talk about this. This is relatively new and something I've sort of been doing probably for the last year or so. And obviously I've used it sort of multiple places, but one place in particular is sort of the femur. That's sort of where things started. And obviously femur fixation and the concepts of sort of femur fractures have sort of changed over time. And this concept of sort of dual implant or you know, sort of dual fixation, whether that be plate nail or you know, new forms of sort of nailing systems for this kind of extreme nailing to sort of solve some of those problems that we have with non-union and control and sort of delayed union and early weight bearing in femur fractures alone. And then that sort of translated into, you know, periprosthetic fractures and that dual implant with the, again, sort of outliving that fracture if you have a delayed union, or hopefully getting them up and walking and mobile and not having the concerns about non-union, malunion, hardware loosening, hardware breakage. And so this has sort of been one of these things that have sort of changed my practice in how I think about femur fractures and periprosthetic fractures in particular. But one of the problems that maintained was interprosthetic fractures. And obviously as the aging population, we're seeing that more and more with a total hip replacement and a knee replacement and then a fracture right in between. Next slide. So really this kind of where things came from, and this was sort of the first, you know, case that we did, and we highlighted this in a case series, but next slide. You know, this was a 91-year-old who was a ground level fall. She's demented. She, you know, lives with sort of assistance. We want her to get back up and walking and moving to sort of that, you know, high level of dementia, high level of function. But this interprosthetic fracture obviously creates a problem for that, right? You know, how do you dual implant this? You can certainly potentially retrograde nail with a supplemental plate, but again, fixation options, proximal and distal, are hard. Anesthesia is telling you that, you know, again, she's not the healthiest person, despite her being, you know, community ambulator, demented, family saying she's relatively healthy. Heart's not all that great. You got to move relatively quickly. And so this was one of the first ones that this was the first one that we had done sort of here at Wake Forest for fracture. And honestly, it was fortuitous. One of our tumor surgeons was doing one at the same time. And I sort of just walked into the room and Will was there. And I said, I've heard about this. I know Dr. Emery, our tumor surgeon, has used this. Give me a little spiel on this really quickly. Sounded like something that potentially we could use. And honestly, I asked if they had 2 light boxes. They said yes, and away we went. So hopefully you're going to see a kind of a theme, how I like to do these. Certainly, I think there's multiple ways to do this, but this is one way that I found that works fairly well consistently. And one of those things is to make it a sawbone. Luckily, a lot of these fractures are relatively simple. And you can sort of get a good reduction on this with a collinear clamp or a Weber clamp or something like that, with that long spiral component that a lot of these people have. And at this point in time, this is a piece of cake. All right, next slide. So once it's reduced, my next step is basically to place the IlluminOss balloon. And this is done relatively percutaneous. This was the first one we did, and we were going to do a laterally based sort of supplemental plate. And so we ended up putting a distal incision there laterally, use that incision to sort of insert that balloon. So you can see the all position there as low as we can go. And then the guide wire that sort of goes up through there. Next slide. And then this is really just like the Seldinger technique. It's like putting in a central line. You have a wire that goes up, you have a catheter that goes over the top of that. The balloon then slides in through that catheter. And so on the left-hand side there, you can see the balloon uninflated. You can then load this up with the polymer. And then on the right-hand side, you can see that intramedullary fit that you get. Balloons come in all sorts of different sizes. They come in different shapes. Some are conical, some are sort of normal. And so again, depending upon the location in the body that you want, if you have a metaphyseal flare, if it's all isthmic, the length and the size, et cetera, you can sort of choose that balloon. The other sort of nice thing is you can sort of sneak it way up top. And you can even have some overlap between that balloon and that proximal sort of whatever that implant is, whether in this case, obviously a total hip, but if you had a nail or something like that, you could do that as well. But then once this balloon is sort of up and in, you basically hook it up to the machine. Our residents always joke and our trainees joke, they turn on like Darude Sandstorm or some kind of techno music. It lights up with a blue light. You wait for it to cure. And then at that point, you can supplement with any sort of fixation that you would like. In this case, we chose a paraprosthetic plate. The other nice thing is that this is drillable. So not only does it give you sort of rotational control stability like an intramedullary implant, but it also provides bony augmentation. So with that osteoporotic bone that many of these patients have, once this is cured, you can drill into it. And actually the first couple of times our residents and trainees did it, they had a hard time feeling cortex. And so you really have to sort of watch yourself because it feels like you are going unicortical that entire way. So you have increased fixation as well, as far as and stability there. Next slide. So this was our sort of intraoperative films. And then next slide, you can see the final film in our flat plate in the operating room. She was immediately weight bearing. I let her walk right away because of, again, thinking of this along the lines of dual implant fixation, dual implant stability, having an intramedullary implant on top of a lateral plate and screw construct. I've got those screws that are going through that IlluminOss balloon. So I have increased augmentation even with that cortical purchase and bony purchase and IlluminOss purchase. Next slide. And at 4 months, 5 months, fully ambulating, healing callus, and she requested to never come back because she was doing fine and she didn't understand the reasoning behind she was driving an hour and a half to see me. So again, this was sort of the one that kicked it off. Next slide. A couple other sort of cases just to sort of highlight. Again, 68-year-old ground level fall, interprosthetic. You can see a relatively long stem, open box. And honestly, our original plan was to plate nail this and go through that box and provide a retrograde nail, touch tips, so to speak, with that total hip replacement, and then put a laterally based neutralization plate on top of that. The difficulty was that once we templated it and once we sort of leveled it out, the shortest nail really wouldn't suffice. It would hit that implant and be proud at the knee. Next slide. It also didn't help that she's a typical Southerner. And so doing something more kind of percutaneous, smaller incisions, potentially could be of benefit as well. Next slide. So again, just kind of looking at those options, plate, nail, dual implant. And I would add on there too, as that third bullet point now, plate IlluminOss as well. Next slide. So again, similar concepts to sort of what you saw. Laterally based incision, we know that we're going to open that up distally, use that to our advantage, see that simple fracture pattern, that long spiral, get again a sawbones type reduction on things. Next slide. And again, kind of evolving in technique here. Typically now I will go medial with the IlluminOss balloon. Again, thinking that if I have support along that medial column, just like a dual plate construct, have that medial column support, prevent that collapse into that medial collapse there, and run it up that column. That may provide additional support for things. And so again, same concept, all insertion, guide pin insertion. Here you can actually see the catheter that is inserted over that guide wire, and then the balloon that's sort of inserted. The other nice thing about that balloon is you can see the markings on how far up and how far down you sort of go. So even you measure it simply like an intramedullary device, an intramedullary nail, but you can sort of sync this or put this a little bit closer or further away from where you are. And then again, blow up the balloon and get that photodynamic stabilization. You can see that nice isthmic fit, rotational control proximally. Adjusted our clamps a little bit to get a little better reduction up top. And honestly, this was so good, you know, looking at it as well as radiographically, put an interfragmentary screw through the fracture, through the IlluminOss, to sort of hold this thing in place. And then at this point in time, it's a sawbones femur. And you just put your periprosthetic plate of choice on the side for neutralization. Again, bony augmentation through that IllumiNos. So all these screws have amazing purchase because you're actually purchasing sort of that IllumiNos implant on top of the bone. Next slide. And there you get it up top. And then next slide. You can see sort of, again, in the operating room, how she did. And then next slide, she goes on to heal. And those are reversed, but you can see the callus formation. Case number 3, again, next slide, another lady, 78-year-old, ground level fall. On the left-hand side, again, an interprosthetic fracture, closed distal femur, right? And a, you know, a proximal, obviously total hip replacement. So that option of plate nail really isn't there. And if you look on this one, unfortunately, this one is not that sort of nice, simple spiral fracture there, and it actually goes relatively high. So again, a plate construct is really your only option on this if you want a dual implant. But getting up that high, while certainly possible, can make people a little bit nervous, and there's a little bit more dissection. There's some other ways around that as well, but again, not ideal oftentimes. And so next slide. Again, here's just the lateral view on that. Next slide. And then again, just because she has a opposite distal femur on the right-hand side, no hip above it. And so again, osteoporotic bone, ground level fall, right? Bilateral femur fractures. I'm expecting that bone to not be wonderful and not be great. Next slide. And so again, you can do next slide. Augmenting, you know, with that IlluminOss device for both stability, strength, to get them up walking, to get them up moving, especially with bilateral femur fractures, but also to augment that bone and make sure I actually have bony fixation. So again, evolving a little bit more here. Oftentimes I'm able to put the plate on first and reduce to the plate, or reduce kind of around the plate. If you do that, you got to be a little bit careful because you don't want that balloon to be hindered by any of your fixation. So oftentimes this will be a very stumpy locking screw in that condylar segment, just to kind of hold that rotation of that plate distally and the location of that plate distally, and then like a drill bit proximally. That way, if you need to remove it or that balloon goes high, you know, that would be something that you can easily change. But then again, that medially based sort of approach, allowing that medial column buttress fixation. Next slide. You can ream if you want to. Oftentimes in these patients, I find that honestly, I don't have to ream all that much. Their canals are fairly spacious, but you can throw a reamer up there if you want to. And again, trying to get that balloon as high as you possibly can to get that sort of dual implant crossover, right? Trying to get that balloon into either around the cement mantle or sort of even around that prosthetic, and so that it can sort of marry itself to it. Next slide. But then again, same thing, slide that balloon up. You can see where the balloon ends and begins very nicely, and then you blow it up. All right. And sometimes you get a little bit lucky. This one didn't do it as much, but sometimes this will even help reduce the fractures for you and sort of push out that medullary canal, push out some of those butterfly fragments, and really restore that medial column support. And again, once this is blown up, you essentially have rotational length control with that IlluminOss implant, and then you can simply fill and drill, so to speak, both proximally and distally. Next slide. Through that IlluminOss, and make sure that it is as strong as it possibly can be. Next slide. And so that's sort of our final construct on this one. Next slide. There's the intraoperative films. Next slide. And just for completeness sake, this was her opposite side, which was too low, I felt, for an IlluminOss at this point. I didn't have enough distal bony fixation within that implant, so elected to proceed with a dual plate construct. Next slide. And lo and behold, that's sort of what she looks like. Next slide. Weight bear is tolerated to both lower extremities. At 3 months, she came back. She was ambulating with a walker, still working with therapy. And I'm actually going to, I looked and I'm actually going to see her back next week. But both sides have healed, and she was up without really any issues, problems, or concerns on either side. Next slide. Pushing the limit a little bit. This was another one that actually just came in last week during the OTA. So lucky I got to stay back and not go because I got to do this. But this was one that a 80s-year-old who was also demented, a little more demented, so was not going to follow commands, was not going to be compliant. And certainly lots of sort of issues with this. This nail was placed in the mid 2000s for a supracondylar femur fracture, had the hip replacement first, had the knee replacement, then had this nail placed, was doing well, and just a ground level fall. And so again, even, talking about interprosthetic fractures, talking about how to sort of fix this and what are your options on things, doing a longer nail really isn't going to help you. You're going to run into that cement mantle. And even doing some kind of a lateral plate fixation, some kind of neutralization bridge plate construct is going to be difficult. The fracture looks simple. It ended up not being as simple as sort of what you would think. And you kind of get a sense of that hindsight 2020, looking on that, what's supposed to be sort of a lateral on that right-hand side where there's that butterfly fragment. And so, one of our thoughts was to just unzip this, open it up, try to get some leg fixation or some interfragmentary fixation there as well to sort of augment that and help that bony healing, given his dementia and sort of lack of, potential compliance. But the other option was IlluminOss. And so next slide. What we ended up electing to do was open things up and actually removed the nail from the fracture site. Next slide. We then had direct visualization and sort of was able to apply, again, a peri-implant plate, periprosthetic plate. And again, this can be anything, your plate of choice. Next slide. But then sort of reducing that fracture to the plate. And then again, same kind of concepts, allowing that medial buttress support, getting dual implant fixation, bypassing that fracture. Next slide. And again, you can see that balloon being blown up, providing that intramedullary control as we sort of blow things up. You cure it. Next slide. And then at this point, again, similar to the other ones, it's just fill and drill. And again, providing that augmented sort of fixation. So you're gaining that benefit of dual implant fixation, strength, mobility, weight bearing, but also, thanks, dude. But also allowing that augmented bone fixation in osteoporotic bone. So each one of these screws through that implant, extremely strong bite, and had no worries whatsoever as far as that stability of that screw or back out of that screw. And these are honestly cortical screws. They're locking screws around the knee implant itself. They're locking screws sort of up in the peritroch region, but every other one of those is a non-locking screw into the IlluminOss, and it feels like you are in 20-year-old, 16, 18, 19, 20-year-old bone. Next slide. And so again, I want to open it up for discussion at this point, but for me, this is relatively easy to insert, right? You talk about doing an intramedullary nail and a plate, or you're talking about plate. You have to go through the knee. You have to open up the knee. You have to worry about the poly. If you're doing a nail, you have to worry if the nail is actually going to fit. I know there are papers out there that you can look up which implant, which nails will fit through, sort of what that concept is. I have done that before. I've failed at that before, even despite the papers telling me it should work. I've buggered up the poly. I hate to say that, but it's true. And again, dual plating, you have to make that incision along that medial side, and sometimes takes longer. So again, this is relatively easy to insert. It's all percutaneous. It's done through for me anyway, this is done through about a 2-centimeter incision, about the medial distal femur. Not hard to insert. And it goes, once that sawbones is sort of created with that fixation to the plate on that lateral side, or that whatever peri-implant, sort of plate you want to use, this takes literally, I had a resident do it about 3 weeks ago, aside from the cure time, put the whole implant in about 12 minutes. So, again, it's not only fixation as far as sort of thinking about dual implant and that construct, but it's also bone augmentation. So for a lot of osteoporotic folks, this is something that I'm using more and more. And it really sort of shines for me anyway in that interprosthetic fracture to increase fixation, to increase stability. And I think that's one place that we have struggled with as trauma surgeons, trying to find the right answer for those to get these people not necessarily fixed. We can do that with that lateral plate, but to allow early weight bearing, to allow these people to get up and move very quickly right away. Next slide. And so again, just for me, from a evolving sort of surgical technique way, make it a sawbone. That's probably the easiest thing to do. And again, typically at this point, that's placing some kind of a plate along the lateral aspect, reducing the fracture, with a collinear or, Weber clamp or something to that plate, make it a sawbone, and then IlluminOss. And that makes it very simple and very easy. And then it's just fill and drill into a sawbones, essentially. So, and I think that's all I got. Thank you all very much. And I'm happy to take any questions or whatever y'all want to do.
Dr. Halverson, thank you very much.